We're going to go over our Narcan protocol update now. So the first thing to remember is that the folks that have overdosed on opiates could have overdosed on any sort of opiates, some of which are very easy to reverse, such as heroin, some of which are very difficult or impossible to reverse, such as carfentanil. And then there's things like fentanyl in the middle of that. So let's talk about what you see when you come upon a patient, because I think what we've seen is our culture, because since we have such a hotbed of opiate activity and overdose in Palm Beach County, that our reflex has really gone to reach for that Narcan. And that is not the right thing to do. When you come upon a patient who is decreased level of consciousness and decreased respiratory drive, what's the emergency here? The emergency is the airway and breathing. So if all you were to do is just start breathing for the patient, the emergency is over, regardless of what the cause is. Whether the cause is stroke, sepsis, opiate overdose, makes no difference. Your first reaction should be actually reach for the bag valve mask and start controlling the patient's airway. Narcan is not harmless to these people. Narcan has actually been shown to kill some of these patients when you cause somebody who is chronically opiate addicted to go into sudden acute withdrawal by giving a big dose of Narcan and waking the patient up. So that's the first thing to put in your mind there, is that if you're going to give Narcan, you have to give it gently. You are not trying to wake these people up. You're just trying to avoid intubating them. So we set up a whole protocol for you to kind of make it a little bit easier, sort of a flow of what you do, when you do. Sometimes you don't have to do anything. So you'll see there are some physiological parameters in there. If you come upon a patient you suspect opiate overdose, and they're breathing more than 10 times a minute, their O2 sats greater than or equal to 92%, and their end-tidal CO2 is less than or equal to 45, you just monitor them. Monitor, O2 perhaps, transport. You let them stay asleep the whole time. That's fine. That's the safest thing to do for them. Let's say that they're not within those parameters then. What do? Well, you try to fix their respiratory status, not by grabbing Narcan, but by giving supplemental oxygen, or by giving them some bag valve mask treatment for a couple of minutes. A lot of the patients will actually respond from that. Because keep in mind, they've given a big bolus to themselves, and it may just be short acting, and then just after a couple of minutes of reviving them, that may be all they need, and that again is the safest thing to do. But let's say you've given them bag valve mask for a couple of minutes, and you know what, they're not coming around. Well, now we carry multiple different formulations of Narcan. So at this point, the decision is, you know what, we have to give them a little bit of Narcan so that we can try to avoid intubating them. So your options are going to be to give IV/IO Narcan, in which case you're going to do 0.5 milligram increments, or you're going to go intranasal Narcan, in which case, again, you've got a couple of choices. You can use the IV formulation, which is the 2 milligram per 2 cc's, or you can use our new 4 milligram spray. So I'm going to leave that up to you depending on the clinical scenario and on the particular neighborhood that you go to, because you may run on a bunch of different calls in a particular neighborhood and know, hey, you know what, we've had a lot of Narcan-resistant overdoses in this particular neighborhood, but maybe in another neighborhood, you know what, they're waking up after half a milligram of Narcan. So that will be on a case-by-case basis that you all, as the experts working this in the field, will decide. But again, the key here is let's try to give the minimum amount of Narcan so we don't have to intubate them. And don't reach for the Narcan right away until after you've addressed the respiratory emergency.
Let's talk about the oxygenation and ventilation of your narcotic overdose patient. Now in the protocol, you'll see there's an algorithm to tell you when to actually give the Narcan to your patient. So you have to check 1, the respiratory rate, 2, you have to look at the pulse oximetry reading, and then 3, you have to look at the end-tidal CO2. Now there's a couple ways of looking at the end-tidal CO2. Number 1, the one that we're probably most familiar with, is your platypus. Now, the interesting part about the platypus is when it actually measures the end-tidal CO2, it uses the nasal prongs. When you're delivering oxygen through the platypus, it comes through the little holes beneath the nasal prongs. Since the oxygen is being delivered through the little holes on the bottom of the platypus, the maximum amount you can flow through there is 5 liters per minute. So regardless of what you have your oxygen bottle set up to, it's only going to deliver a maximum of 5 liters per minute. And then the piece on the bottom here is to measure the patient's respiratory rate. So that's one way of getting your end-tidal CO2 reading. Another way of getting your end-tidal CO2 reading is using the inline filter, which you're all familiar with from using with the endotracheal tube. So if you know that you're going to be providing supplemental oxygen via BVM to your patient, my recommendation would be to do it this way. So you would go ahead and tie the inline filter on, and then your nose, the nares are wide open at this point. So you can go with a regular standard nasal cannula at this time to provide supplemental oxygen to your patient. So you could come from the top of the patient in a very non-traditional manner where you would almost put it on like a sunglass band because you're just providing supplemental oxygen. You could go ahead and plug that nasal cannula in and run it about 15 to 25 liters per minute to start building up the oxygen saturation. Then you could come over with your BVM. This would be plugged into your monitor, and you could go ahead and start providing slow bag valve mask ventilations to increase your SpO2 and decrease your entitled CO2. But before you do that, make sure you have your patient positioned properly. So I know that these situations are not always that luxurious where you have a ton of room to position them and ventilate them before giving the Narcan. However, if you have a little bit of space to work, the premier place would be on the stretcher. You would shim the patient up to approximately a 20-degree angle, and then you would get some padding underneath of the head to get it to where the patient's ear hole is in line with their sternal notch, and that maximizes the airway patency. So once you've maximized the airway patency, you've increased their oxygenation by giving them a high-flow nasal cannula, you've tied in your entitled CO2 filter line with your BVM, you can provide slow breaths approximately from anywhere from 1 to every 6 seconds to 1 to every 10 seconds in an attempt to go ahead and restore your patient's respiration status. So let's talk a little bit about providing ventilations with your bag valve mask. Now, if you're going to be using the nasal cannula with the BVM, remember you're going to need 2 oxygen sources to appropriately oxygenate your patient during that time. So when you go to use the BVM, there's a couple things to take into consideration. If you look at the American Heart Association guidelines, they don't even allow you to provide BVM usage alone. They say it's a 2-person operation. And the reason being is because it's very difficult to achieve a great seal by one person doing this while simultaneously squeezing the bag. So there's a couple different ways. If you have 2 people, you can provide something which is called the thumbs down technique. So you take the BVM, you put it on the bridge of the nose, and you put the thumbs down while simultaneously pulling back on the patient's jaw, which is hyperflexing the neck, which is maximizing your airway patency. Now, if you don't have that luxury, you can do it as a 1-person operation. So same thing, you would put it on the bridge of the nose, you would push down on the mouth with the bag valve mask while simultaneously pulling back on the jaw. Now, everyone probably learned the CE technique or the EC technique. What they're saying now is it's a VE technique. So basically, you would come in, you would push down on this while pulling on the back corner of the jaw, and then simultaneously squeeze your bag. And you provide nice, slow ventilations at approximately 1 to every 6 seconds or 1 to every 10 seconds. While you're doing this, you're going to be watching your patient's pulse oximetry as well as watching the entitled CO2 to try and lower it down to that number that we're trying to achieve, which is below 45. Now, the last thing I want to cover when using the bag valve mask is take into consideration the size of the equipment that you're using. If you look at this one, the adult one, it's a 1,650 ml bag. So each time you squeeze, if you put all of this into the patient, you've put 1,650 mLs of air into their chest cavity. We know that the lung capacity is anywhere from 5 mLs to 10 mLs per kilogram. There's no way that any lung can take up to 1,650 mLs. So what does that mean? If you over-squeeze the bag, you increase interthoracic pressure, and in turn, you actually fill up the stomach. Why is that important? Well, later on during your call, while treating your narcotic overdose patient, if you need to perform airway interventions such as intubation or putting in an eye gel, and you've hyperinflated the stomach, you have now greater the risk of aspiration and vomiting during your procedure. So take into consideration that this is a very big bag, and the question comes up quite frequently, should we use the child bag? Now, the child bag contains 500 mLs. Here's the problem with that though. That might work if the patient was intubated. This patient is not intubated. There's lots of soft tissue in the airway, and we know the ideal number is anywhere from 500 to 600 mLs of air. So you would have to squeeze that bag absolutely perfect. Your patient would have to be absolutely positioned perfectly for an effective ventilation to occur with the child mask. So child mask is not the answer. When squeezing the bag valve mask, we learned that when you squeeze up here, you're getting the greater portion of the bag. If you take your hand and just move it a little bit further south, and if you look, there's a couple of lines down here, 3 lines particularly we're referring to. If you move it just down here and you squeeze each ventilation in at the lower portion of the bag, this should deliver the adequate amount of volume needed as long as you have a good face to mask seal. So let's talk a little bit about Narcan administration for our narcotic overdose protocol. So there's multiple different ways of giving Narcan. The first option you have is to go IV or IO. So you can establish an IV or an IO if you choose, and then you have your Narcan, which we're all familiar with, right? Your dose would be 0.5 milligrams, and you can titrate this in until you get your desired effect, and you can slowly improve your patient's vital signs if the pre-oxygen did not work. Now, another way of doing it is you can give Narcan intranasal. Now, same thing, pre-filled syringe. You could go ahead and put on your MAD device to the end of your pre-filled syringe. Again, like I said, we've already pre-oxygenated our patient. We've tried to assist their ventilations. We use the nasal cannula and the bag valve mask. We've had no improvement, and now it's time to move to intranasal Narcan or IVIO Narcan. So a couple of administration tips here. Number one, you want to inspect the nares. So if you have any nasal drainage coming from the nose, or you notice there's a bunch of congestion in their nose, you might want to clear that out. And what I mean by clearing that out is you can use your suction device and you could go ahead and make sure that you have a clear passage for the medication to be atomized into their nasal cavity. So position them. It just so happens the correct positioning is the same as the airway positioning. You want to tilt the head back. You want to take their occiput. We call it the crown, so you put the crown to the ground, and then you want to come in from an angle after you've cleared the nasal cavity, and then you want to rapidly disperse this. So if you're using this device, it is imperative that you rapidly disperse this. Some of the disadvantages to using this device, though, is you can only put 1 ml per nair. So if I administered 1 ml, I would have to rapidly disperse 1 ml and then switch over here to this side to administer the second ml. And the reason being is because absorption. So this is going to go into the vascular plexus, which is a very vascular enriched area. However, if you overload the nasal cavity, the absorption rate drastically decreases. That's why we have the 4 milligram Narcan. It actually makes things very easy, but it can also make things very difficult. So let me further explain that. 0.1 mLs equals 4 milligrams when using this device. So that works fantastic. You don't have to worry about rapidly dispersing this and then switching it over to the other nair and rapidly dispersing it. This is a one-time use. You put it in the nair and you go ahead and rapidly disperse it and you've delivered 4 milligrams. The downside to this is it's very difficult to titrate this in. So what we found out by talking to the manufacturer is the bioavailability is roughly anywhere from 44 to 48% when administering this. So essentially you're delivering 2 milligrams of Narcan to your patient. So just understand that if you give multiple doses of this, you're probably going to wake up your patient in a couple of minutes and they're going to be extremely agitated and aggravated and you might have to further sedate them. So if you decide to use this, be cautious when using this and make sure you give it time to take effect before even thinking about administering another dose.